Surgical management of portal hypertension. Portal hypertension is an elevated pressure in the portal venous system, typically resulting from increased resistance to portal blood flow. Common causes include liver cirrhosis, portal vein thrombosis, or other conditions affecting the portal circulation. Surgical management is generally considered in cases where medical and endoscopic treatments fail or as a bridge to liver transplantation. Goals of surgical management: 1. Reduce portal pressure. 2. Prevent complications such as variceal bleeding, ascites, and hepatic encephalopathy. 3. Improve the quality of life. Types of surgical procedures. 1. Portosystemic shunt surgery. These procedures divert blood flow from the portal venous system to the systemic circulation, bypassing the liver. Non-selective shunts, used to reduce portal pressure significantly. Examples: end-to-side portocaval shunt, connects the portal vein to the inferior vena cava. Side-to-side portocaval shunt creates a parallel connection between the portal vein and the inferior vena cava. Mesocaval shunt links the superior mesenteric vein to the inferior vena cava. Selective shunts divert blood flow selectively to preserve hepatic perfusion and minimize encephalopathy risk. Examples: distal splenorenal shunt, DSRS, connects the splenic vein to the left renal vein, used mainly for esophageal variceal bleeding. 2. Devascularization procedures, esophagogastric devascularization, used when shunting is not feasible, especially in patients with severe variceal bleeding. Involves ligation of veins around the stomach and esophagus to control variceal bleeding. Examples: Sugiura procedure, a combination of esophageal transection and gastric devascularization. 3. Splenectomy, often combined with other procedures, such as a distal splenorenal shunt in patients with hypersplenism and thrombocytopenia. 4. Liver transplantation, definitive treatment for portal hypertension caused by liver failure or cirrhosis. Addresses both the underlying liver disease and complications of portal hypertension. Indications for surgical intervention: refractory variceal bleeding despite endoscopic and pharmacological therapy. Portal vein thrombosis with complications. Refractory ascites not responding to medical management. Severe hypersplenism causing pancytopenia, as a bridge or adjunct to liver transplantation. Complications of surgical management: hepatic encephalopathy, especially with non-selective shunts. Shunt thrombosis or occlusion, persistent or recurrent variceal bleeding. Infection or post-operative sepsis, increased risk of liver failure due to reduced hepatic blood flow. Current trends: transjugular intrahepatic portosystemic shunt, TIPS. A less invasive, radiologically guided procedure has largely replaced open surgical shunts in many cases. It creates a shunt between the portal and hepatic veins using a stent, reducing portal pressure effectively. While surgery is now less common due to advances in endoscopic and radiologic interventions, it remains an essential option for select cases.